My pleasure to be with you. The title of my talk and my disclosure, of course. So this is the outline. I will divide my talk in 6 parts. First, the potential benefits and drawbacks of tracheostomy or tracheotomy, the current practice regarding this technique, what should we do, percutaneous dilutional versus surgical tracheostomy, the prediction of mechanical ventilation duration, and this is really a key issue regarding the potential indication for tracheostomy, of course. We will then review the data from the most recent randomized controlled trials, and finally, maybe make some recommendation. First, of course, the rationale for early tracheostomy is pretty good. I have indicated on the slide the potentially advantages of early tracheostomy regarding the work of breathing, the felicitation of oral hygiene, of course, the airway security, which could be a major issue in the ICU. We have also pretty strong data showing that early tracheostomy could improve the patient comfort, of course, decreasing the need for sedative administration, and really facilitating the mobilization of the patient in the ICU. We have less strong data, of course, as you know, regarding whether or not using early tracheostomy it's possible to decrease ventilator-associated pneumonia, decrease the duration of mechanical ventilation, and at the end of the day, is it possible using tracheostomy to lower ICU and hospital mortality? But be careful. We have also a list of potential complications associated with tracheostomy. As shown on the slide, in many studies, it was possible to document the prevalence of emphysema or pneumothorax, of course. And sometimes those complications could be really dreadful, as you know, as shown on the slide. And in that case, as you know, if the patient removes the cannula, could be a real nightmare for putting again the cannula into the neck. So could be very dangerous. Of course, the most dreadful complication of tracheostomy, as shown by Massimo, is tracheal stenosis. And as you know, the diagnosis could be really delayed, a couple of weeks or months after ICU discharge. So this is also a real issue, of course. Remember, we need to be very prudent regarding the discharge of patient tracheotomized in a general world. And this is one of the studies having clearly documenting that there is a real danger discharging a tracheotomized patient into a ward with no specialized nurses and doctors. And in that study, as you can see, the mortality was pretty high in patient discharged cannula in place. So be careful. What is the current practice when our ICU physician performing tracheostomy? We have pretty good data based on observational studies. As you can see, we are still doing a lot of tracheostomy after 10 or 14 days in the ICU, as shown on the slide. And as you can see, the maximal prevalence of tracheostomy is roughly just above 10% in those patients requiring a prolonged duration of mechanical ventilation. But as you can see, even if the median day for performing tracheostomy is roughly 9-10 days after the onset of mechanical ventilation. But in fact, there is a wide variation depending on the doctors in the ICU, going from 1 or 2 days after the onset of mechanical ventilation until 3 or 4 weeks. So waiting a lot before performing the tracheostomy. So we have no real homogeneity in our practice worldwide, in fact. This is exactly the same, whatever the country. As said by Massimo, we have now pretty solid data showing that probably we need to abandon the surgical technique and perform a percutaneous tracheostomy. There are many advantages. This is a meta-analysis published in Critical Care 3 years ago, based on 14 RCTs testing the two techniques in a pretty large number of patients, roughly 1,000 patients. Really, using the percutaneous technique, it was possible to go a little bit faster. You will win maybe 13 minutes, maybe. But more importantly, you will decrease the bleeding, as shown on the slide, and maybe also, and this is also important, infection or inflammation around the stoma of the tracheostomy. We have good data showing that, of course. There is a caveat, maybe sometimes doing a percutaneous technique, you could meet some technical difficulties. But now, using a one-step dilatation technique and using bronchoscopy, at least initially, just to be sure that the placement of the endotracheal tube is correct, and before and during the puncture of the trachea, using bronchoscopy will really decrease those technical difficulties. So remember the technique, and there is probably a learning curve, of course, but after you will be able to do that very safely and very quickly in the ICU. This is the conclusions. Is the mechanical ventilation duration predictable? This is, as I said before, a key issue because it will drive the indication. Should we do an early tracheostomy or a more later tracheostomy? Yes, we can use some scoring for determining the factors associated with a prolonged duration of mechanical ventilation. This is one study we did a couple of years ago, looking for the risk factors of a prolonged duration of mechanical ventilation. As shown on the slide, of course, the severity of admission at time of admission, using, for example, the Apache score, was linked to the duration of mechanical ventilation. The indication for mechanical ventilation, community-acquired pneumonia, ARDS, of course, septic shock or severe septic shock, and also some organ failure, because of course the renal dysfunction of failure is really associated with a bad prognosis and a pretty long duration of mechanical ventilation. So from a statistical point of view, it's using those scoring systems, it's possible to have a pretty good sensitivity and specificity, as shown on the slide. Pretty good specificity and sensitivities, but the predicting value were not so good, in fact. As you can see, the sensitivity was only 70% only, and the specificity may be exactly the same, 60–65%. So, in other words, in many cases, using those scoring systems, you will not be able really to predict in whom patients you need to do an early tracheostomy. This is another study recently published, and as you can see, it was asked to the doctors in the ICU at the time of the onset of mechanical ventilation to predict the duration of mechanical ventilation, to predict patients with at least 1 week for the mechanical ventilation or 2 weeks of mechanical ventilation. So as you can see, the prediction done by the doctors at time of admission to the ICU was not so good. And as you can see, the positive predictive value, which is really the important information we need to make a decision, was really very bad, 44%. In other words, the doctors were able to predict a prolonged duration of mechanical ventilation, at least 2 weeks of mechanical ventilation, which is probably the duration we need to perform a prolonged, an early tracheostomy. So it was possible to predict that in only 44% of the patients. Maybe the good thing is that the negative predictive value was good, above 85%. And therefore, if the doctors at the onset say, no, we don't need to probably to use a prolonged duration of mechanical ventilation, in that case, you need to postpone and to wait for performing tracheostomy. So, what are the data issued from the randomized controlled trials? This is really the key issue, of course, also. So, we have maybe 3 recent studies, randomized, very well controlled, having evaluated the potential benefit associated with early tracheostomy, a tracheostomy done during the 3 or 5 first days of mechanical ventilation. The first one was done by our Italian colleagues, led by Massimo Antonelli, in fact. The primary endpoint of the study was the cumulative incidence of ventilator-associated pneumonia. Interestingly, in that study, from the 210 patients randomized to prolonged intubation before a potential indication for tracheostomy, in 90 patients from those 210 patients, in fact, the patient was extubated or died before day 14. And therefore, in those patients, no need at all for tracheostomy, of course. And this is probably the major benefit for waiting for tracheostomy, not doing a tracheostomy in a patient that will be extubated, weaned from the mechanical ventilator very early during the course of the disease. In that study, it was not possible to reach the primary endpoint. There was a small benefit, a trend, in favor of early tracheostomy regarding ventilator-associated pneumonia, but the p-value, the magical number, as you know, was 0.07. Sorry, Massimo. Okay, but nevertheless, there were some benefits clearly documented in that study regarding the number of days with no mechanical ventilation, the ventilator-free days, comparing the 2 groups. So a statistically significant benefit in favor of early tracheostomy regarding early tracheostomy compared to prolonged intubation. And this is also the case for the length of stay in the ICU. So some benefit, at least, in that study. But remember, 43% of the patients randomized to prolonged intubation was, in fact, extubated or died before 2 weeks of mechanical ventilation. The second study was a single-center study done by our team in Paris. 216 adult patients after cardiac surgery, a very complicated cardiac surgery. And we selected those patients because we have a pretty solid data showing that if those patients after cardiac surgery are still on mechanical ventilation on day 4, there is a big chance for a prolonged duration of mechanical ventilation. So this was the target population in our study. The primary endpoint was the number of ventilator-free days to day 60 post-randomization into the study. Once again, only 29 patients, which is 29% in fact, assigned to prolonged intubation received a late tracheostomy, exactly for the same reasons as in the Massimo study, because those patients were weaned from the mechanical ventilator. In our study, it was not possible to demonstrate a benefit regarding the duration of mechanical ventilation, exactly the same number of mechanical ventilation free days on day 60. Exactly also the same survival in the two groups. But a clear benefit regarding the sedation of the patient, the time spent on heavy sedation, less haloperidol use for agitation, for example, or delirium, less unscheduled extubation, a better comfort, earlier resumption of oral nutrition. So some benefit regarding the comfort of the patient in the group with an early tracheostomy, as shown before. The third randomized control trial was done in the UK and recently published in JAMA. It was a larger study, including more than 800 patients. So a pretty big study with a power to show the benefit of early tracheostomy if this benefit really exists. The primary endpoint was the mortality. Very ambitious endpoint, of course. Is early tracheostomy able to decrease the mortality on day 30? Exactly the same results as in the two previous trials regarding the group of patients randomized to prolonged intubation. In many, many patients, after 2 weeks, those patients were extubated or died. Exactly the same survival in the two groups. No benefit regarding the mortality. And the duration of mechanical ventilation was a little bit shorter compared to patients randomized to late tracheostomy. 15 days versus 13 days, as shown. Not, once again, statistically significant, but maybe very close. Exactly the same benefit as in our study regarding sedation, as you can see. It was possible to improve the comfort of the patient. Based on that, a couple of years ago, it was possible to pull all the randomized controlled trials and to do a meta-analysis regarding the mortality. We have now a clear demonstration that doing early tracheostomy does not improve the survival of the patient. There is a benefit maybe regarding pneumonia, but I am not sure because, as you know, by definition, those randomized trials are open. It's not possible to randomize the trial, to blind the trial, of course, and there is a high potential for bias, of course. Interestingly, in the Great Britain study regarding the antibiotic exposure, exactly the same antibiotic exposure in the two groups. So I am not sure that really it's possible to decrease the rate of ventilator-associated pneumonia. In that meta-analysis, it was possible to document a benefit regarding the duration of mechanical ventilation. So this is probably a potential advantage of early tracheostomy. Is there a benefit in some population of patients? As you know, all of us are maybe convinced that in patients with, well, this is my last slide, in those patients with a brain injury, for example, could be a better indication for that. The data are not so good. So my own bias would be summarized in the slide. Should we perform a very early tracheostomy within 3 or 7 days of mechanical ventilation? Probably or certainly not. So maybe there are some exceptions. This is medicine, of course, but should be very rarely performed. Should we perform tracheostomy after 10 or 12 days of mechanical ventilation? Probably yes, at least in some patients. But before to do that, you need maybe to think a little bit more and really weighting the potential advantages versus the risk and the complication of the technique. So thank you so much for attention.